Hello, my name is Dr. Payal Kohli, and I'm a cardiologist who specializes in non-invasive and preventive cardiology. I graduated from Harvard Medical School, and I currently own and run a general cardiology practice in Denver, Colorado. In this video series, we're tackling 5 common misconceptions around the use of coronary CT angiogram, or CCTA, in the diagnosis of coronary artery disease for our patients. And we'll be debunking some myths. This is the 4th video in our series. Another common misconception that I've often heard is that even if I wanted to order a CTA from my patient, they couldn't get one. Well, I'm here to tell you that there have been many recent changes that have now made the coronary CTA much more accessible to our patients. As a reminder, recommendations for non-invasive testing have changed significantly in the last couple of years. And part of this is that coronary CTA has been elevated in the chest pain clinical practice guidelines. So many insurance companies are now actually requiring the coronary CTA to be ordered first because of this guideline update. So patients who had previously been unable to get coronary CTAs may now be able to get them. So my biggest piece of advice for you, if you've fallen off that horse, it's time to get back on. And if you failed at getting a coronary CTA covered in the past, try ordering it again because times have changed and guidelines have changed. Now, one thing to note is that you will need to document the symptoms for the patient really well. So if they're having chest pain, dyspnea, fatigue, you'll want to make sure that this is in the order because symptomatic patients are typically covered and even guideline recommended to have that coronary CTA first, even without prior authorization in some cases. Now, you may experience coverage issues if you order a stress test before a coronary CTA. So in my personal experience, when I order those coronary CTAs for my symptomatic patients, I really haven't had a lot of pushback from Medicare, Medicaid, and even many of the commercial payers. Usually, I like to throw in a reference to the ACC/AHA chest pain guidelines somewhere in the order or in the clinical note so that if it is getting prior auth, it's more likely to get approved. And of course, if you don't have coronary CTA at your facility, you can find it at a nearby imaging facility that offers the test. If your patient can't get scanned in the hospital, you can also try sending them to one of those mobile CT scanners. If your patient has an abnormal CT scan with a 40 to 90% stenosis, I would suggest that you add a conditional order, which is a test on top of the coronary CTA called FFR-CT. This helps us to understand the physiology and whether the specific lesion is causing hemodynamic impact and whether it meets criteria for what we call FFR-guided revascularization. And this can be ordered automatically by the CT reader or the interpreting physician, but you have to put it in your initial order. So usually what I do is create an order set that can be placed into the system. And again, it's a good idea to try to allude to those ACC/AHA guidelines where FFR-CT is mentioned for those with a 40 to 90% stenosis because this can really help with coverage. Another part of this misconception is the belief that coronary CTA costs a lot more out of pocket for the patient than a SPECT test. Now, in this day and age, that may not be true. The financial responsibility of the patient is highly dependent on their individual health plan. We all know that. But the insurance industry standard is typically a 20% coinsurance or a copayment. So based on the CMS rate, SPECT costs more than a coronary CTA, so the patient could be actually responsible for a higher out-of-pocket cost for a SPECT than there would be for a coronary CTA. It's also important to keep in mind that there are a lot of freestanding imaging facilities that have coronary CTA technology, which makes this an outpatient procedure, as opposed to SPECTs, which are often done in a hospital setting, and that can confer a facility fee or a hospital fee on top of the testing fee. What's missing, obviously, from the story is whether the patient is on a high deductible plan and how far along they are to meeting their deductible requirement. Now, if we set all that aside and just consider the potential cost to the patient for the coinsurance, you see that it's quite a bit less for coronary CTA as compared to SPECT. So let's summarize. Our misconception was that even if we ordered coronary CTA for our patients, they wouldn't be able to get it. I think we've debunked this today by showing that the updated clinical practice guidelines is now actually recommending coronary CTA first, and that insurance coverage is actually much more broad as a result of this. But you need to practice that good documentation, and you need to make sure you have patients' anginal equivalents in the chart and reference those ACC/AHA chest pain guidelines to really help ease those approvals. And if your patient asks you just how much is this going to cost, recognize that a coronary CTA is likely to cost less than a SPECT. Be on the lookout for other videos debunking misconceptions regarding the use of coronary CTA. And really think about adding an order set for coronary CTA into your electronic medical record for your next suspected CAD patient. After all, we all went into medicine to do the best for our patients, and this means keeping up with the latest evidence and changing our behavior accordingly.